Hello and welcome to another video in Foundations in Maternal and Newborn Health. In today's video, we're going to be talking about abortions. And so there are two main classifications of abortions, broadly. There are induced abortions, induced abortions, and these would include things like medical abortions, so that would be taking certain medication that can induce labor or evacuation of the uterus. This would also include surgical abortions. So this would be a surgeon going in and removing any sort of material in the uterus. And then there are also self-administered abortions. So these would be abortions that someone would do to themselves, by themselves, without an accompanied or the advice of a medical professional. So we've talked about the mechanism of medical abortions before. Generally speaking, these medicines induce evacuation or induce labor just very early on in pregnancy, so you evacuate the entire uterus. The other type of abortion is a spontaneous abortion. Spontaneous. And these are also more commonly known as miscarriages. And so we'll focus this video on the spontaneous abortions. So we've kind of touched on some aspects of spontaneous abortions in other videos. So we'll start with causes. And in the genetics unit, we talked about aneuploidy being a common cause for a miscarriage or also a molar pregnancy, other things like that. So aneuploidy or other genetic diseases are thought to make up approximately 50% of all spontaneous abortions or all miscarriages. There are other causes of spontaneous abortions, which include things like malnutrition. So if the mom's body doesn't believe that she can support the fetus isn't growing well enough because of this malnutrition, this can trigger a spontaneous abortion or a miscarriage. You can also have some chronic diseases in the mother, and specifically untreated chronic disease. So things like untreated diabetes, some untreated kidney diseases, other things like thyroid disorders, again, untreated. These can induce spontaneous abortions or miscarriages because the mother is not producing proper hormones to maintain a fetus. You can also have infections. And so in the immunology unit, we talked about teratogenic infections. So this would be our TORCH acronym. Some of these infections can kill the fetus, and when the fetus dies, oftentimes, if it's early enough, the mother will undergo a spontaneous abortion. The last one that we'll talk about is an incompetent cervix. And this is essentially when the cervix is no longer strong enough, or the woman's cervix can't hold the baby inside the uterus. And so this is often a cause for repeat spontaneous abortions in the second trimester. So if a woman has a history of second trimester spontaneous abortions, you may want to think about an incompetent cervix. So this is usually around 16 to 24 weeks. And so the baby starts to get quite large at this period of time. It starts putting pressure on the cervix. And so if the woman's cervix, due to a genetic issue or what have you, her cervix isn't functioning properly, the baby can basically be delivered or fall out in the second trimester because the cervix isn't functioning properly. And there are treatments for this, so that would be one thing to try to identify, and you can treat that prematurely to prevent a spontaneous abortion in the second trimester. Okay, so continuing our conversation on spontaneous abortions, there are subtypes of spontaneous abortions. The first is a threatened abortion. And so these are the three factors that are important when determining what stage of a spontaneous abortion a woman is in. So whether she has vaginal bleeding, whether her cervix is open or closed, and whether or not she's past tissue. And so in a threatened abortion, the woman hasn't undergone an abortion yet. It's not guaranteed that the abortion will go through. It's just threatened. It's just a potential for happening. And so in this instance, we usually see vaginal bleeding. The cervix is closed. And of course, there's no tissue that's been passed because the baby's still inside. And in fact, an ultrasound can be done. And you should still hear a fetal heartbeat. So the woman is threatening to have an abortion. There's a risk of an abortion imminent, but the baby's still alive at this point, but there is some vaginal bleeding and there's a risk that the mother could lose the baby. So if this progresses further from a threatened abortion, it can become an inevitable abortion. And in the inevitable abortion, there's still vaginal bleeding, but now the cervix is open. And so if the cervix becomes open from a threatened abortion, this now moves it on to an inevitable abortion where the abortion is now for sure going to happen. And so at this point, there's still no tissues passed, but their tissues will be passing shortly because the cervix is now open. The next stage is an incomplete abortion. And again, there's vaginal bleeding. The cervix remains open. But at this point, some products of conception or some tissues have passed. So not all of them, but some of them. And that's what makes it an incomplete spontaneous abortion, because there's still some tissues that remain inside the uterus. And then the last step of a spontaneous abortion is a complete abortion. And so at this stage, there's usually still some vaginal bleeding, but now the cervix is closed. So the cervix closes because all of the tissues have now passed. So there is tissues passed, there is products of conception passed, and at this point, all of the products of conception should have passed. And so you might be able to imagine after complete abortion, you can determine whether it's threatened or complete. Both have a closed cervix, both have vaginal bleeding, but if you do an ultrasound, of course, the uterus should be empty during a complete abortion. There will not be a fetal heartbeat, of course. The fetus is gone at this point, and so that would make it a complete abortion. There are a couple other subtypes of abortions that I will mention here as well. So there's also a missed abortion. And so this would be an abortion that happened outside of medical supervision or outside of even the patient being aware. So the abortion has already happened already. And so that should hopefully make sense. It's a missed abortion. It was missed by the clinician. It was missed by maybe even the patient. So the abortion's already happened. The other type of abortion I'll mention is a septic abortion. And so this can be a spontaneous or even an induced abortion that ends up with a complication of an infection of the uterus. So any abortion with an infection. Okay, so this is usually an infection of the endometrium or some retained products of conception, which I'll talk about in a second. But this can be both an induced or in a spontaneous abortion if the woman becomes septic. And so lastly, we'll talk about retained products of conception. Retained products of conception. And so, of course, in this instance, you may have what appears to be a complete abortion. The cervix may even close, but not all of the tissues have passed. So you may have kind of a combination of both a complete and incomplete, where some products of conception are left behind. And so this is ideally identified to prevent a septic abortion, because these retained products of conception are now no longer being cared for by the fetus. Of course, the fetus is now either dead or gone. So there may be a piece of the fetus itself or of the placenta left inside of the uterus, and this dead piece of tissue is no longer being cared for by the mother. And so this piece of tissue can become infected with often bacteria that ends up rotting or becoming septic. And so the woman can end up very, very ill from a retained product of conception, leading to a septic abortion. And so this is just something important to keep in mind. If a woman has had an abortion or has had a missed abortion or is in the process of an abortion, retained products of conception and a septic abortion are things to keep in mind, to be wary of.